4, 3, 2, 1. We are live now.
Good morning, everyone. Welcome you all to the fourth episode of the Jharkhand Orthopedic Association PG webinar series. And today the theme of our this webinar is knee joint, and we have very distinguished three speakers with us. Dr. Devendra from Ganga Hospital, Coimbatore, Dr. Prasoon Anand from Dhanbad, and Professor Samir from All India Institute of Medical Sciences, Nagpur. So before starting this webinar, I would like to invite our Secretary of the Jharkhand Orthopedic Association, Dr. Nirmal Kumar, to welcome all our speakers. Over to you, sir.
Thank you, Dr. Manish. It's my pleasure and at the same time honor to welcome all the speakers. As rightly introduced by Dr. Manish already, actually they don't need introduction in a way, and probably today being Sunday and in spite of holiday, I mean their presence itself shows how committed they are to teaching. So on that note, I would welcome you all and wish you all a great teaching program today. So over to Dr. Manish to start the proceedings.
Thank you, Dr. Nirmal. In this webinar, we have three sessions and we have three speakers who will talk about on the different aspects of surgical approaches, fixation regarding the fractures of the knee joint. Now we have also the three different moderators, Dr. Rajesh Thakur sir from TMH Jamshedpur, Dr. Virendra from Bokaro Hospital, and myself from All India Institute of Medical Sciences, Devgarh, who will be moderating this session. So I would like to invite the moderator of the first session, Dr. Rajesh Thakur sir, to initiate the proceedings. Over to you, sir.
Good morning. Thank you, Dr. Manish. So after a gap of few months, we are again starting this very good webinar series. This is very important for PGs and including we also, because returning to basics every moment is very essential. I would like to introduce one of the eminent speakers, Dr. A Devendra. He is consultant in orthopedics trauma in Ganga Hospital. He has training in advanced orthopedic trauma in Austria. He is in charge of bone bank in Ganga Hospital. He has 14 international and 65 national presentations, and he is a recipient of 6 gold medals in the state and national meetings so far. So he is co-author of 36 international trauma publications, and he is also co-author of chapter on initial management of open injuries in the textbook of Rockwood and Green on trauma 8th and 9th editions. So he will be talking on approaches around knee joint. And please, Dr. Devendra, continue from here. Thank you, sir.
Thank you, sir. Thank you for the kind words, and thank you for inviting me to join you. So I'm going to share my screen. So is my screen visible, sir?
Yes, sir. It's visible, sir.
So today my topic is to describe about various approaches around the knee to access the distal femur as well as the proximal tibia. So for the proximal tibia, we have anterolateral, posteromedial and posterolateral approaches. And for approaches to the distal femur, we have lateral, anterolateral and medial approaches. So coming to the proximal tibia, the anterolateral approach, it actually enables us to access the lateral column of the proximal tibia. So whenever we have a fracture of the lateral tibial condyle, or if we want to do some bone grafting procedures for the non-unions around the proximal tibia, and a treatment of some infections, biopsies of the tumors, and also harvesting of bone grafts in children, we can access anterolateral area of the proximal tibia through anterolateral approach. Here, it doesn't directly overlay the bone. So we put the incision over the proximal tibia where there is a lot of musculature, and then retract the musculature. The muscle that we see routinely is tibialis anterior, which is retracted posteriorly. And then we can extend the incision when it is needed to access the joint also. So the lateral tibial plateau can be easily visualized up to the tip of the fibular head. And we can actually see, if we do an arthrotomy, we can visualize the lateral meniscus also. So here is a depicting picture where the anterolateral approach incision has been made and then exposed to access the joint. We can see that the medial lateral meniscus has been retracted by using a suture material, and we can access the anterolateral aspect of the proximal tibia easily with this approach. Let us see a case scenario where we can use this approach. We can see that there is a lateral tibial condyle completely comminuted, depressed, and these kind of fractures need arthrotomy and elevation of the fragments. We can see that the incision has been made like a curved incision over the Gerdes tubercle, and then the Gerdes tubercle is the place where IT band gets inserted. And here we are elevating the tibialis anterior and then retracting posteriorly. And then to access the joint, we have to incise the, we have to cut the IT band horizontally so that it is easy to close it back. We can see that the meniscus is been trapped underneath, which is retracted by using a suture material. On the outer aspect of the meniscus, we can take a skin suture so that we can see that it can be retracted superiorly, and then we can access the fracture fragments. We can proceed for further fixation. It allows us to elevate all the fragments, and then we can do a good fixation like this for the lateral tibial plateau and achieve a good outcome. Coming to the medial or posteromedial approach, this approach is useful to access the medial column and also the posteromedial region. And whenever posteromedial approach can be used when there is a medial and also the posteromedial coronal split fractures, and it is difficult to access these kind of coronal split from the posterior approach. So it is posteromedial approach gives us better access to the coronal split, and then we can do a arthrotomy also to access the to visualize the joint surface, and we can reduce the coronal split fragments through this approach and then proceed for fixation. The position is we need to elevate the opposite hip by placing a bump underneath the opposite hip so that we can access the posteromedial portion, and we need to flex the knee so that gastrocnemius and soleus muscles are relaxed and then external rotated so that posterior and medial portion of the proximal tibia can be accessed easily. So this is the landmark how we place the incision. The vertical line it marks the joint line, and from there a curved incision over the posteromedial portion can be placed like this. And then first step is to identify the pes anserinus, which constitutes sartorius, gracilis, and semitendinosus. So sartorius is the first structure that we identify. Whenever we see the anterior border of the pes, that marks the anterior border of the sartorius tendon, and we need to reflect the sartorius tendon posteriorly, and we identify the bursa underneath that, which we can release it. And then we need to identify two tendons. Identifying the sartorius is quite easy because it is quite broad structure, not like a typical single strand tendon structure. It is a broad structure which can be incised easily by using the knife. But gracilis tendon and semitendinosus lies more vertical, oblique position. They lie in oblique position, and we need to identify them both and retract them by using either K90 or infant feeding tube so that we don't incise them. The anterior border of the gracilis, the first structure that we see is sartorius, and once we retract, we see the gracilis more anterior and semitendinosus more posterior. The anterior border of the gracilis, it marks the when we retract the gracilis tendon, the anterior border, we can see that MCL can be seen just underneath the gracilis tendon when we retract the tendon posteriorly. So here, and once we see that we should not incise the MCL. If we want to do an arthrotomy, we can just do an arthrotomy anterior to the MCL and then visualize the articular portion, and then partially we can release the MCL, superficial MCL, to access if there is a coronal split underneath the MCL. So we should not release the MCL completely. Here, this approach allows us to access both posterior to the MCL and also the anterior to the MCL. Here we can see there is a coronal split. So we can see that there are two anteroposterior screws that are placed for the coronal split. And this kind of coronal split can be accessed by medial approach in supine position rather than posterior approach in lateral position. So in supine position, posteromedial incision, we can do an arthrotomy and then reduce the fragments. For this, we need to retract the pes anserinates, MCL, and then do the arthrotomy. So coming to the posterior approach is mainly indicated when you have a tibial plateau fracture with the spike more medially and centrally located rather than more towards the periphery. If the posterior spike is more towards the center of the proximal tibia, it is difficult to access by posterior medial incision, and it is better to turn the patient in lateral position and then go back to the posterior aspect. So this approach, posterior incision, it gives us access to the PCL avulsion fractures and also the posterior medial column, which can be fixed through incision. Here, the position is we need to place the patient in prone position, and then we need to make sure that we have a good availability of the space for knee extension and flexion, so that the fracture usually, sorry for my bad voice, usually we can reduce the posteromedial fragment by extending the knee joint. So we need to make sure that we have a good free movement space for the leg to move before we start the incision. Tourniquet can be used if the tourniquet can be used in most of the cases, so that it is bleeding can be less in this area. So the incision is like this, where it is placed like a curved inverted L-shaped incision from the popliteal crease, and then curved it down onto the posteromedial border of the gastrocnemius. And once we place the incision, we retract the gastrocnemius laterally, and then we see the popliteus muscle, which can be erased partially to access the posteromedial portion. So this is an X-ray where we see that it is a simple fracture in X-ray, but we see that the CT scan, it shows that it is mainly the spike is pointing towards the posteromedial portion, more towards the center. These kind of fractures, sometimes it is better to access from the posterior approach rather than from the medial incision. So that here we can see that the incision, if you place a curved incision, we can access up to the posterolateral portion, and PCL avulsion also, if they have a fragment, we can reduce it and place the screws. So this is how we can do posterolateral and posteromedial portion, which can be accessed through the posterior incision. Here is one more patient who has a grossly comminuted bicondylar fracture. We can see that the posterolateral corner is mostly located posterior to the fibula, and there is a comminution with ejection of some of the articular fragments superiorly also. We can see that there is a comminution on the posterolateral and posteromedial comminution is seen. In these kind of fractures, it is always difficult to access by single incision. We need to proceed for two incision, posteromedial fragment separately, and then posterolateral fractures fixation separately. So let us see what are all the approaches available for this kind of fractures. Medial approach, we have seen medial fracture, we can go through a posteromedial incision. And for the anterolateral portion, there is an extended anterolateral incision where we can extend the incision quite posterior, identify the fibular head, and then now so that we can access the posterolateral portion if it is a simple fracture, and then retract the tibialis anterior so that the lateral portion of the proximal tibia also can be accessed. There is one more approach called Frosch approach, when there is a posterolateral depression, posterolateral tibial plateau, which is very close to the fibular head, which gets masked by the fibular head. In this region, to access, it is difficult by extended lateral approach sometimes, and Frosch approach gives us better visibility of this kind of fracture. So this is this approach allows us, without doing the fibular osteotomy, to access the posterolateral portion, which is masked by the fibular head. So here the incision is placed with the patient in lateral position, and the incision is placed and over to the girdis tubercle, and then extend it both superiorly, inferiorly, quite extensively. This approach is modified by Mancini, where extended anterolateral approach can be used. Can be combined with the Frosch approach, so that we can access both posterolateral as well as anterolateral approach, and without needing one more incision for the lateral incision, we can access both posterolateral as well as anterolateral portions of the fractures. The advantages being, we don't need to do the fibular osteotomy, less damage to the posterolateral corner structures. We can visualize directly the fracture fragments, and we can do, if required, simultaneous lateral arthrotomy also with this approach. The disadvantage being, we cannot extend it distally, because the trifurcation of the artery comes just 5 centimeters from the joint line, and it is difficult to address additional medial tibial plateau fracture with this incision. And the common peroneal nerve can be, the advantage being here is, the common peroneal nerve can be mobilized both anteriorly and posteriorly freely, and it allows to work both both lateral and medial surfaces also. So here is one of the same patient whom we had a approach like this. The incision is placed over the fibula, extended up anteriorly and then horizontally up when the patient is in lateral position. So we can see that we're able to access the posterolateral portion posterior to the fibular head by retracting the flexor hallucis, and then common peroneal nerve anteriorly. And then we can access the anterolateral portion by placing one more incision, one more access surgical window anterior to the fibular head above the girdis tubercle, but through the same incision. We can see that we are able to access the anterolateral portion and also the posterolateral portion with the same incision. But here the requirement is, we need to place the incision, patient in lateral position. So that we can access like this and then get reduced both posterolateral and anterolateral fixation. Here is one more lady who had a posterolateral comminution. We can see that some of the fragments are trapped below the between the fibular head and the tibial plateau. 3D images tells us better fracture pattern here. The lateral portion is comminuted, PCL is avulsed, and the posterolateral fragments are trapped between the fibula and then proximal tibia. In these kind of patients, we need to have we need to access the posterior aspect also to fix the PCL. So in this patient, we can place 2 incisions. First is to place the patient in complete prone, access the posterolateral portion. We can see that the flexor hallucis muscle is completely avulsed from the fibular head, and then the fibular head also is broken completely. The common peroneal nerve is retracted, and then we can access the posterolateral portion of the proximal tibia, and then we can proceed for fixation. See here it allows us to elevate the posterolateral portion, align the fragment, and then stabilize it from the posterior to anterior, and stabilize it with screws. And PCL also has been stabilized through the same incision by another cancellous screw. And since there was avulsion fracture of the fibular head with the lateral structures of the joint, which are very important for the stability, it was secured with a circlage wire, and then plating also has been done through the same incision. So whenever we have, see now we have seen a posterolateral portion when there is a depression with a comminution which is trapped between the fibula and then proximal tibia, we can access through an extended anterolateral approach or Frosch approach. where we can access both posterolateral and anterolateral portion. When you have only posterolateral depression, only the posterolateral depression, small depression, articular depression, we can place a vertical small incision just over the fibular head and then retract the common pallidum nerve. We can directly access the posterolateral depression portion like what we see here. So far we have seen approaches to the proximal tibia, medial, posteromedial, anterolateral, extended anterolateral, and posterolateral approaches we have seen for the proximal tibia. Now let us see the distal femur. One of the common approaches that we use is swashbuckler approach to the distal femur fractures. The patient is placed in supine position on a radiolucent table, and tourniquet is generally not required when we are using when we are trying to do a distal femur fractures, except in only the articular portion. If it is involved, we can choose a tourniquet. Otherwise, it is better to avoid tourniquet for distal femur fractures fixation. Here, the patella is marked, and then the incision is placed just next to the patella, so that we can get a plane between the quadriceps and then vastus lateralis, so that we can access the anterolateral portion of the distal femur. Here, along with iliotibial band, the vastus lateralis is retracted, and then rest of the quadriceps is retracted medially. So we can see that the whole structures are retracted, and the parapatellar retinaculum can be incised by using a knife, and then we can go on to do the arthrotomy and then to access the distal femoral condyles. So the swashbuckler approach is the plane between the vastus lateralis and then rest of the quadriceps muscle. Vastus lateralis along with IT band is retracted posteriorly, and the rest of the quadriceps is retracted medially. But when you have a posterolateral femoral condyle fractures or only involvement of the lateral femoral condyle, we can directly access them by doing a lateral approach, where the approach is described between we elevate the whole vastus lateralis anteriorly, so that the lateral portion is accessed. So here we can place an incision straight down from the mid thigh down up to the tibial tuberosity, and then identify the quadriceps, elevate the vastus lateralis completely up, and then take care of the perforators, where we see the perforators which can cause a lot of bleeding if we don't cauterize them. And then when we extend the incision down up to the tibial tuberosity below the vastus lateralis, we can access the lateral femoral condyle as well. But the disadvantage being we cannot access the medial femoral condyle through this. So if you want to access both medial and lateral femoral condyle, it is better to go by a swashbuckler approach. If you want to access only the lateral femoral condyle, then we can use this incision, so that lateral femoral condyle can be reduced easily with this approach, and then stabilization. One of the other advantages with the anterolateral approach is this. Lateral approach is that to reduce the fragments, we can bring the leg out with the knee inflection. We can place something, bolster or a soft tissue, cloth underneath the knee, and then flex the knee so that the muscles gets relaxed, and then we can visualize the to some extent the intercondylar extension. But the medial femoral condyle combination we cannot address through lateral approach. It is better to go by swashbuckler approach. So, and then we need to close the tissues accordingly, so that there is no any problem. And coming to the medial approach to the distal femur, the lateral approach, we have seen lateral approach to access the lateral femoral condyle, swashbuckler approach to access both the medial and lateral femoral condyle when there is an extension to the shaft metaphyseal region. When you have only medial distal femoral condyle fractures, like coronal splits, Hoffa fracture, medial Hoffa fracture, or when you want to do, when there is a bone defect on the medial side, when you want to do medial plating and then bone grafting, medial approach is important. So here the medial incision is placed just posterior to the most prominent portion of the femoral condyle. So it is adductor it is called the adductor tubercle, where the adductor tendons gets attached, and then it is extended quite posteriorly. But this approach gets limited by the presence of the vessels which crosses the femur close to the bone at distal third, middle third junction from anterior to anteromedial to posteromedial portion. The vessels, neurovascular structures passes and become the popliteal structure. So we need to be careful not to extend the incision beyond the place where the adductor magnus tendon is attached. So this is how it is been placed. The approach is made between sartorius and then the vastus lateralis muscle, and then we identify the adductor magnus which gets attached to the adductor tubercle, and then we here around the knee. There are 6 geniculate arteries, 3 on medial side, 3 on lateral side. All 6 together they form a genicular plexus, which are responsible for high blood circulation, high blood supply around the knee. And it is always very important to identify the branches of the genicular arteries and make sure not to damage them. And if there is a bleeding, if it is coming in the way of your plate fixation, maybe we can ligate one of the branches. So the adductor magnus tendon inserts into the adductor tubercle anteriorly. So that limits our approach. We cannot access them posteriorly. So if you want to access more posterior, you can retract the adductor magnus tendon anteriorly and then make the limb into figure of 4 and then go to the posterior region to access the posterior half of the femoral condyle. So we can see that the vastus lateralis is completely elevated, sartorius is retracted posteriorly, and then we identify the adductor magnus tendon, which gets inserted to the adductor tubercle. It is always important to make sure that we are not damaging the perforators around the distal femur, and the incision is, the approach gets restricted when the muscle bulk starts of the vastus medialis. So above that, if you want to do any plate fixation, we can do a MIPO kind of, we can slide the plate and then access them by using stab incisions more anteriorly and then try to fix the plate. So this medial incision is important even when you see a medial side bone defects like this. So it is important to place the medial plate so that we don't have the varus collapse of the distal femur. So medial plating of the femoral condyle, or when there is a defect on the medial side with comminution, we can choose this approach so that the plate fixation can be done. So popliteal vessels, as I mentioned, we need to be very careful. Very difficult when there is a vessel injury, or if you want to access the popliteal vessels. To some extent, we can expose, but it is very difficult to access the vessels freely. If you want to access the vessels when there is a bleeding, we need to go more posterior and then access to the popliteal fossa. So, and sometimes when there is a medial parapatellar approach also can be used in certain situations. And when you are using a medial parapatellar incisions, especially when you want to do a total knee replacement, when you place the incision onto the medial border of the patellar tendon, you need to be careful about infrapatellar nerve and saphenous nerve. Patient can complain of numbness in a patchy distribution over the anteromedial portion of the proximal tibial region. So, the skin sensation can be blunt post surgery if you damage these nerves. So the incision is placed just medial to the patella, and then it is extended superiorly and inferiorly so that we extend the we make the incision through the medial patellar retinaculum and then go to the joint surface. This medial parapatellar approach can be used for total knee replacement surgeries. And medial parapatellar incision can be used when you have both medial and lateral HOFA fracture as well. So we place the incision by quite inferior up to the tibial tuberosity, retract the patella completely outer side so that we access both medial and lateral femoral condyle. And when we flex the knee, we access both the condyles. And this approach can be used apart from total knee replacement both HOFA fractures when you have medial and lateral. This is one of the approach which helps us to fix the fractures. Thank you.
Thank you very much, sir. This was really a big topic, but in this short period, you touched upon almost everything and very clearly explained what important structures we encounter and how to handle them. So again, we always stress upon understanding the exact fracture pattern of these fractures. So why it is important to exactly locate and understand those fracture pattern, and why in tibial plateau posterior column fractures we need to approach from the posterior side, different approaches of the why it is important, sir. Thank you, sir.
Yeah, posterolateral corner is one of the important region. If it is a simple fracture pattern, we can access by anterolateral incision. But if the fragment is more posterior, the fibular head and lateral collateral ligament, they mask the access to the posterolateral portion. And when the patient starts walking, if it is not reduced, it can cause problems like instability. So posterolateral portion accessing is quite difficult by anterolateral incision. That's why the posterolateral approach has come. Posterolateral approach, initially it was described like we can do a fibular osteotomy, but now currently we don't use the fibular head osteotomy. So we don't need to do, we can access it by retracting the common peroneal nerve and then rest of the soft tissue structures. And then we can access the posterolateral portion. Posterolateral portion, reducing the fracture is very important to achieve good stability while walking. And also when the patient starts flexion, when you have complete knee flexion, where the femoral condyles gets in contact with the posterolateral portion, there can be a problem or quick progression to the arthritis. That's why we need a good approach to the posterolateral portion. When there is a comminution, it is better to access the posterolateral portion and then stabilize them.
Thank you, sir. Thank you very much, sir.
Thank you, sir.
I would now, Dr. Manish, it's over to you.
Sir, excuse me, sir. Dr. Manish, I have one question from Dr. Devendra. Can you allow me?
Yes, sir.
Yes.
Morning, sir. Actually, the most common PG question, if you have to deal with the lateral and medial column in the proximal tibia, what will be the distance between the two incisions? That the PG most common question, sir.
Yeah, usually the distance is, as mentioned in the literature, it is 6 to 7 centimeters. We need to have gap between the medial and lateral incision. That's why I suggest that we place the incision quite posteromedial region of the proximal tibia on the medial side, and then anterolateral incision, it is a lazy curved incision over the girdis tubercle. Usually we get the space of around 6 to 7 centimeters.
And one more question, sir.
Yeah.
What is your message if the patient is coming with the distal femur and proximal tibia both having the same sequence, same time fracture? What is the common message you pass on to the PG for examination of the limb as well as approach, distal femur first or proximal tibia first?
Sorry, sir, I didn't get your exact question. When you have a distal femur and proximal tibia fractures?
Yeah, both. Then what will be your message for the PG to examine the limb? How and they should proceed?
Yeah. Actually, the topic was only approaches, so I didn't go into the depth of examination and other things. See, whenever you have a proximal tibia fracture, the important complication that we see is either neurovascular injuries or compartment syndrome. So always when the patient comes to the casualty, we need to make sure that there is no compartment syndrome by examining the neurovascular structures. And also we need to look at the passive extension, active extension of the toes. When the patient is able to do whatever may be the fracture pattern, if the patient is able to do active dorsiflexion, that means there is no compartment syndrome. Okay, so and one more thing, if the patient is quite comfortable on the stretcher, even though the fracture appears to be quite large, quite bad, and then the soft tissue swelling is quite high. Or when you have blisters, where sometimes patient comes after 6 hours, 7 hours, by the time blisters also might have set in, started appearing. So when presence of blisters is not an indication for fasciotomy. Presence of blisters doesn't mean that there is a compartment syndrome. Okay, so presence of blisters means there is a involvement of there are two types of blister, hemorrhagic as well as serosanguinous blisters. So when you have involvement of the only epidermal layer, you will have serosanguinous blisters. When there is a dermal layer involvement where the vasculature is seen, so it can be hemorrhagic blisters, so that blood component also is seen. So even in spite of presence of all the blisters in the limb, it is not an indication for fasciotomy or this one. It is not it doesn't mean that there is a compartment syndrome, unless patient complains of severe pain, not able to control, rolling on the bed in spite of giving pain medications. And if he is not able to do active dorsiflexion, when we do dorsiflexion of the toes, there is a severe pain, then that indicates that there is a compartment syndrome. That is first thing. And we see floating knee injuries quite commonly. Floating knee injuries, distal femur and proximal tibia fractures. One of the worst outcomes that we see in our routine practice in trauma is floating knee injuries, because the amount of energy that required to make all these fractures is quite high, and most of them they present with open injuries ranging from small wounds to large wounds. So always we need to be very careful about looking at soft tissue injury, neurovascular injuries, then only come for the bone. So soft tissue injury and neurovascular injuries we have to rule out before we do anything for the floating knee injuries. So in the casualty, always check for the pulse, dorsiflexion of the toes. The moment we see the patient, when you ask the patient to start moving the toes, he tries to do like this, but there will not be any active extension. Yes. So whenever you are checking the toe movements, always look for active dorsiflexion of the toes and passive extension of the toes if there is a pain or not. This is very important. Just presence of plantar flexion alone doesn't mean that there is no problem. We need to look at dorsiflexion of the toes also, and then sensations over the foot, so that there is no neurological injuries.
Thank you very much. Thank you.
Thank you. Yes.
Dr. Manish, can I come in? I would like to raise one question.
Yeah.
So,
yes.
As you showed a few of the cases also, it's quite common to come across fibular fractures. I mean, in the proximal part of the fibula I'm talking about, along with proximal tibia fractures. So, I mean, would you like to take advantage of that? And since we always avoid kind of a situation where we have to go for fibular osteotomy, but the nature has done that for us. So, will that be of use to get extended approach to maybe posterolateral corners, even if you have gone through anterolateral approach? What's your take on that, sir?
Yeah, actually, sir, when you see a proximal fibula fracture, if it is a proximal third fibula shaft, then no way that we can make a fibular, we cannot retract that. There is no advantage. And when there is a fibular head combination, still it is difficult to retract them. I've approached 2 cases where there is a fracture. I thought I might come out without, like how we do elbow incision. When there is a olecranon fracture, automatically we don't need to do any olecranon osteotomy, and directly we can visualize the elbow and then go on to face. But here, it is not the same way that it is so easily we can visualize the joints. So I have noticed that it is quite difficult to access. But if it we can the incision, skin incision is, we can use it as a extended anterolateral approach, so that we can access the fibular head. Like some of the cases in fibular GCT, giant cell tumor, when I'm excising the fibular head, I use this incision extended anterolateral approach. So I retract the nerve and then identify this one. And then when I make a cut, I usually see whole lateral proximal tibia. So if it is a fractured one, but the soft tissue disruption is quite high. So the extended anterolateral approach, if you want, you can use when you have a fibular tip avulsion or fibular head fracture. But sometimes we might face it a little bit difficulty. I mean, if you are comfortable with that, we can try. Otherwise, regular incision, we can use that.
And for the benefit of postgraduates, and
Yes.
for even for all of us who are regularly using these approaches, regarding the force approach, as you talked, so what would be the common peroneal nerve exploration? To what extent distally we are supposed to explore it and kind of mobilize it to protect it, and at the same time not to injure it?
When I heard about the fracture for distal posterolateral injuries, I tried for a few patients, but on a routine basis, when we do type 5, type 6 fractures, I routinely do around, in a month, around 10 cases of proximal tibia fractures on an average. So if we see the utility of this Frosch approach, it is very limited as the days passes by. Actually, I noticed that the advantage of this approach is very, very limited, except that when you have a posterolateral corner injury, lot of comminution, which you cannot access by any other means, then only this approach, I think it is useful, because I practice only trauma. So only in trauma situation, when we see a lot of posterolateral corner injuries also. So when there is a simple posterolateral depression, when you have a bicondylar fracture with posterolateral depression, we can use a small Steinman pins, which were published in IJO also. So we can use Steinman pin and then elevate the fragment and then get reduced. Only very limited portion of the cases we use this incision, sir. This approach. So not on a routine basis, we use this approach. And sorry, and you asked about extension of the common peroneal nerve. Common peroneal nerve, it is always it should be tension free both when you move anteriorly and posteriorly. For that, I put an incision, quite extended incision. So when you are identifying the nerve, I want the nerve to be freely mobile both anteriorly and posteriorly. When you are accessing it to excise the fibula in case of tumors, or when you are accessing the fracture. So we extend the incision and then identify the nerve well below, at least 7 to 8 centimeters below, and then 3 to 4 centimeters above, so that we don't cause common peroneal, because the traction of the nerve, even slightest, even when we are using the suction, suddenly if it sucks the nerve, it can cause traction, neuropraxia. That is the amount of sensitivity the nerve has. So we should not use the suction also near to the nerve, and then we should not retract too far anteriorly or posteriorly, and then use some retractor kind of this one. Use something like Penrose or some infant feeding tube, and then make sure that you are not moving it too hard, too fast. So for that, I extend the incision quite superiorly and inferiorly. I make sure that it is released quite extensively, no small incisions, sir.
Thank you, Dr. Nirmal. Now we will move to our next session, and the next session moderator is Dr. Virendra from Bokaro General Hospital. Over to you, Dr. Virendra.
Yeah. Thank you, Dr. Manish. On behalf of JOA, I would like to invite Dr. Prasoon Anand for his talk on surgical stabilization for various kind of distal femur fractures. And few welcome notes about Dr. Prasoon Anand. He has almost 18 years of post-MS orthopedic experience. The field of expertise is orthoscopy, trauma, as well as arthroplasty. He worked in Tata Motor Hospital, Jamshedpur, as a consultant, and he was regularly involved himself in DNP teaching as well as training programs. He was also worked as administrative in the same hospital. He has multiple national as well as state journal publications. And after that, after lifting the Tata Motors, he worked in various corporate hospitals as a senior consultant. And now he is running his own hospital, that is Shri Govind Hospital at Dhanbad. Now over to Dr. Prasoon Anand, sir. Please deliver your talk.
Thank you, Dr. Biren. Thank you for your nice word. And I thank Dr. Manish and our JOA secretary, Dr. Nirmal Kumar, for giving me this opportunity. So I welcome all. So I will share my screen. My screen visible now?
Yeah.
Hello?
Yes, sir. You are visible. Your slides are visible.
Okay.
Get it full slide, sir.
Is this
Yeah.
okay?
Yeah, please start.
So the topic, our topic to discuss today is the different surgical stabilization method in distal femur fracture. So what are the objective of this presentation is to discuss what is the distal femur anatomy. Because if you do not know our territory well, it is very difficult to beat our enemy. So thorough understanding of the distal femur anatomy is must. What are the challenges we should anticipate? What are the challenges involved in stabilization of the distal femur? And so that we can anticipate what are the problem we are going to face. What are the principle involved? Various implant option we have at present. So regarding the anatomy, if you see the anatomy of the distal femur end on, so it has got trapezoid shape. Medially, there is a laterally there is 10 degree of slope, and medially there is a 25 degree of slope. So it is narrower on the anterior aspect and broader on the posterior aspect. And then there is a intercondyle sulcus posteriorly and intercondyle notch posteriorly, and there is a patellar groove anteriorly. So what is the clinical implication of using knowing this anatomy is that if we are putting a plate any implant medially or laterally, we should be aware of these slopes and the shape of the femur. At the same time, if we are putting a screw from lateral to medial, we should understand that if you put this blue mark, I don't know where the cursor moves. Yeah, this blue area is the safe area where we can put our screws. If we go more posteriorly, it will encroach upon the intercondylar notch, and if you go anteriorly, there will patellofemoral joint invasion. And if you see in an AP view, and we put a screw anteriorly, because anterior there is a less space. If you put a screw anteriorly and see in the AP view, even the screw come here, and in AP we will find that is within the bone, but it may jut out from the bone anteriorly, and it can give a very painful condition, painful restriction of the knee joint movement. So we do not want that. So anteriorly it has to be smaller and directed from anterior to posterior, and posteriorly we can go for more longer screws, but we have to mindful about the intercondylar notch. So what are the challenges we have? Often we have got a very small articular block, and stabilization of that articular block is many times a challenge. Often we have got the comminution and poor bone stock. Nowadays, the type of fracture we are getting is in young patient with a very high energy fracture, and elderly patient because of osteoporosis, there is a both poor bone quality as well as the comminution. There are large deforming force around the knee joint, and the long lever arm itself is a challenge. And most often, because of high energy trauma, it is associated with some degree of open fracture and bone loss, and that itself makes the challenging fracture even more challenging. So what are the treatment goals? Like, we need a perfect reduction of the joint surface and restoration of overall limb length, alignment, and the rotation. That is must for have a good satisfactory result. What are the principles involved in stabilization? As we always know and keep insisting to our DNB and PG students, always anatomical reduction and absolute stability for the distal articular block, and functional reduction and the relative stability for the metaphysis and the diphyseal segment. Where we do not want absolute stability, it has to be relative stability, minimal invasive. For the implant option we have, going to discuss or something, but first, implant option at present we have got joint spanning external fixator. When there is other neurovascular damage is there, as a damage control, we can use the joint spanning external fixator. Then the most commonly used a distal femur anatomical locking plate used on the lateral surface. Then we have got the buttress plate and screws. We have got retrograde nail, dual implant, medial and lateral, whenever is indicated, need to be used. And of course, in a very exceptional case, mega prosthesis is also an option. So before starting, always it is good to go for the classification. What we follow is a classification, and it is a simple thing. Like A is extra-articular and ranging from A to A3, it shows the level of the comminution at the metaphyseal diphyseal region. B is partial articular, B and B1 is sagittal plane, medial and lateral condyle fracture. Wherever the B3 is the coronal plane, what we call Hopper fracture, and C is intra-articular fracture. C1 is simple intra-articular and simple metaphyseal fracture. C2 is simple articular but comminution at the metadiphyseal region, and C3 is the most complex fracture with the complex intercondylar as well as the metadiphyseal fracture. So as far as the implant is concerned, the most widely used nowadays is the anatomical locked plate, lateral and femur anatomical locked plate. The advantage of using this plate is angle stable, multiple point of fixation is there. In a small articular block, we have got multiple holes so that the even a small articular fragment can be fixed very well. Is ease of application because it is anatomically made, so pre-bend, ease of application, and it can be used in a minimal invasive and the bridge plating mode. Disadvantage, like all plates, these are load bearing device and not good alone for medial combination in many ways. In spite of all the success rate, still many literature suggests that it has got considerable failure rate, up to between 20 to 40% failure rate is there. But who is the culprit? We must decide. The plate design alone cannot be responsible for the failure. We must understand that the way we are putting it maybe has got some fallacy. That is why it has got a high failure rate. So we'll look into what are the fallacies in putting the plate and what is the correct way of using this plate to have an optimal success rate. So some of the example I like to. So some of the example, like in this case, there's a distal femur fracture which has been stabilized with the lateral locked plate very well. If you can see the length, alignment, and the rotation all has been reasonably well established. So there is no problem as far the anatomical reduction is there, but still the fixation fails and the plate and screws are broken. So what are the reason? We'll see later on. Again, there's a C2 fracture. There's a lot of comminution, extensive comminution in the metadiaphyseal region. Fixed reasonably well. Longer plate had been used, but because of this long span of comminution, still the plate, this fixation looks inadequate. But despite of again gaining the length, alignment, rotation, everything looked well. The plate bent and it broke. This case, anatomy has been so perfectly reduced. Everything is okay. Even the surgeon has tried to fix and successfully fix even the smaller fragment all around smaller fragment has been fixed with a screw and the plate has been applied. Looks so good, but it failed, the plate broke. Again, this case, reduction is very good, anatomical, everything looks well. Lot of screws has been put and everything looks well in the first X-ray. But again, there is a failure. This case also, everything looks good, but the plate broke and there is a non-union. What are the success mantra to get a optimal outcome from the locking plate? Always one has to use the longest possible plate in the given circumstances, and it should be no less than 11 hole. 11 hole, 12 hole, 13 hole, whatever the longest plate. Yeah. And for the metadiaphyseal segment so that the vascularity remains.
Dr. Prasoon.
Means not all is.
Dr. Prasoon, you can switch off your video for better internet connectivity. Not sharing, Dr. Prasoon. You can just switch off your DP status for better. Actually, network is something problematic on either side. We can't hear you, Dr. Prasoon. Unmute yourself.
Okay, is it okay now?
Yeah, it is okay now. You can
so
go
far,
on with your presentation.
So far, have you
we are listening. We are listening.
Yeah, okay. So I was discussing about what are the success mantra for the optimum outcome.
Dr. Prasoon, share your slides. Kindly share your slide, Dr. Prasoon.
Yeah, is it okay now?
Yes, it is perfectly okay.
Please proceed, Prasoon sir.
Yeah. Okay. So I was talking about the hybrid fixation. So all the screws should not be either the cortical or locking screw. So it should be mix of cortical and the locking screw so that the fixation remains but still pliable. It is screw density has to be between 40 to 50% maximum. We have 10
something wrong about
each segment should be used.
Dr. Prasoon, there is some technical glitch. We can't hear you. Dr. Prasoon, are you there? Dr. Prasoon? I think there is some technical glitch. Dr. Prasoon, are you listening?
Okay. हाँ. Okay. Is it okay now? Visible?
Perfect, Dr. Prasoon. You can proceed.
So, and medial augmentation, whenever required, should be always considered. So, whenever in doubt, the medial augmentation should be done. So, talking about the medial augmentation, what are the indication for the medial augmentation? So, if the distal articular block is very short and we are fixation, we will be able to have done. If there is a periproctic, then can use almost always required. If there is a medial gap, there is a combination or medial gap more than 2 centimeters augmentation, and in spite of
Dr. Prasoon, are you there? Dr. Prasoon?
yes, I am here. Yes. Is it visible now?
It is visible.
Yeah. Okay, sorry for the inconvenience. Okay, so we are talking about the medial augmentation. Short distal fragment, osteoporosis, periprosthetic fractures, medial gap more than 10 centimeter, and whenever there is a doubt, we should go for the medial augmentation. And there is a data, enough data is there. So if you expose only for the lateral side, the vascular damage to the lateral approach only is 25%. And when we combine with the medial stabilization augmentation, there is a damage of vascularity 29%. So there is only 4% increased loss of vascularity if you add a medial exposure only. So it shows that it is not a very significant amount of devascularization. So whenever required, the medial stabilization exposure should be done. And as Dr. Devendra has said, if we go for the modified swashbuckler approach, we do not need to take a separate approach. With the same approach, both lateral and the medial stabilization can be done. But if we are taking a lateral approach, then another medial approach needs to be taken. Now, there's a lot of way to medially stabilize the fracture. Dr. Sunil Kulkarni et al. From Miraz, they have demonstrated beautifully the use of Ender's nail and the tense nail, and the lab also they have done the study, cyclic loading, and they've shown that this works. This elastic fixation itself works. So this is the advantage of using the Ender's and tense nail from the medial side, that it is sort of minimal invasive, easier to do, quicker, and it is effective too. But in a long, extensive combination, whether it will be serving its purpose, maybe it is doubtful, and may need to augment with a better, stronger implant. So the most commonly augment what we use medially is the plate. And the plate, there's a plethora of plate present. And the plate can be most commonly used, can be just 3.5 or 4.5 recon plate or locking plate or the T buttress plate. People has used all sort of plate, like Philos plate, fixed medial tomofix. They have very well is the proximal lateral fits very well, and the company has a plate specially made to fit on the medial side of.
Dr. Prasoon, are you there? Okay, meanwhile, Dr. Prasoon is getting his connection right. We have with us Dr. Pankaj sir. He is the President-elect of Jharkhand Orthopedic Association. Very good morning to you, sir.
Morning, good morning.
Dr. Prasoon, are you there? Dr. Prasoon?
I think some internet issues are there. Yeah.
Dr. Prasoon is back.
Yeah. Am I audible?
Sir, you are audible, but your voice is breaking, sir. Dr. Prasoon? Dr. Prasoon, are you there? Okay, meanwhile, Dr. Prasoon is checking his connection, everything. With the permission of Secretary and President-elect, can we move to the third session? Meanwhile, Dr. Prasoon check his connections and everything.
Yeah, Dr. Manish, I think it's better to go ahead with the next lecture probably.
Yes. Dr. Prasoon, can you answer? Okay. Okay, I am starting the third session, and we have with us Professor Dr. Samir, who is professor and head and department of orthopedics in All India Institute of Medical Sciences, Nagpur, as the speaker of this session. He is fellow of arthroscopy surgery in South Korea, had done advanced course in medical education from NMC New Delhi. He is assistant editor in Indian Journal of Orthopedics. He is Associate Editor General of AIIMS Nagpur. He is also Associate Editor of International Journal of Orthopedic Research. He had 47 publications in national and international journal. He is Treasurer of Arthroscopy Society Nagpur. He is ex-Joint Registrar Vidarbha Orthopedic Association. Sir, it is our privilege and honor to have you on the GOA platform. Over to you, Samir sir.
Thank you, Dr. Manish, for kind introduction. Good morning, Dr. Pankaj, Dr. Birendra. So, thank you very much for giving this opportunity to me. And
Prasoon sir, kindly unshare your slides.
so I'm trying to share my screen now.
Prasoon sir, kindly unshare your slides.
Okay.
Okay, sir.
So, can you see my PPT?
Yes, sir. We can see.
Yes, sir. So, I'm going to begin with this particular topic, that is different type of proximal fracture and how they are surgically fixed. So, it's a quite vast topic to cover in the allotted time, but I will try to go only cover the basics of the proximal fracture that needs to be understood in the PG student perspective. So, we commonly in emergency get some proximal fracture which on seeing it becomes seems very difficult to manage it. And not only we need to see the fracture which is visible on the X-ray, but also we need to see we need to have a holistic approach for the soft tissue which are around them, because there are many a time they're associated with the soft tissue injury. So the objective of the lecture is going to be to understand the complexity of the proximal tibia fracture, appreciate the mechanics, classification, and achieve the rational treatment plan. That is for the articular, metaphyseal, and for the management of the soft tissues. So tibial plateau fractures are mainly the intra-articular fractures, and as the principle says, all the intra-articular fractures require a perfect anatomical reduction and absolute stability, whereas the metaphyseal and diaphyseal fractures can have a relative stability. So you need to understand the fracture biomechanics. So there are the different type of forces which are acting on to the proximal tibia fractures. Either it can be varus or the valgus deformation. So mainly the valgus type of injury will result in the fractures of the lateral tibial condyle. Whereas if it's a varus deformation, you can have a fractures of the medial condyle. Then there are the axial compression or the associated flexion and extension will also result into different type of fracture patterns. So the injury, it can be either direct or a indirect type of injury. So basically, we are dealing with a two subset of people. So young patient with a good bone structure, but usually it's a high velocity injury. So a lot of soft tissue injury is also associated with it. And also in an elderly age group, it's a low energy trauma, but we need to tackle the osteoporosis in those patients. So how to classify? We have this AOTA classification, which classifies mainly the type A are the extra-articular fractures. So type B are the tibial plateau fracture, which can further classified into type B1, B2, and B3, depending upon the different fracture pattern. And type C fractures are the complete intra-articular fractures, which can have either a metaphyseal comminution or a simple articular, or it can be an articular comminution. So apart from this, we have another classification that is the most commonly used, is the Schatzger's classification. So we have this fracture type 1, that is the split. Then type 2, it is associated with a split depression. And type 3 is only there is a central or a peripheral depression is there. Type 4 are the resulting from a varus force. These are the high velocity injury resulting into fracture of the middle tibial plateau. And we have the type 5, these are the bicondylar fracture, but there is a bridge of the metaphysis which is communicating with the epiphysis. And type 6, where there is a metaphyseal diaphyseal. So there are certain limitations of the AOTA and the Schatzger's classification. They are mainly based on the X-ray based classification. So it cannot provide the 3D analysis fracture, and evaluation of the posterior tibial fracture is limited. So it can lead to some underestimation of the severity of the fracture or the bone injury. So Lau in 2010 introduced this classification. It's the CT scan based classification, in which he has divided the proximal tibial plateau into 3 parts, that is the anterolateral, anteromedial, posterolateral, and the posteromedial. All these fracture patterns in this particular area will have a separate mechanism of injury, and depending upon the mechanism of injury, we need to plan our fixation patterns. So it has a 0 column fracture where there is a pure articular depression is there, but the fracture line is not extending into the peripheral part of the bone. Then we have the 1 column fracture. So here in this case, you can see the fracture line is extending from the anterior to posterior, but there is a single fragment. So it is termed as a single 1 column fracture. So it can be very well managed with the anterior column fixation. Now this is the 0 column fracture. Now here you can see there is a fracture which is involving the anteromedial as well as the posteromedial tibial condyle. So it will term as a 2 column fracture. And there is a 3 column fracture where all the 3 columns are involved. So this is the classification in detail, the 3 column classification. So advantages of this 3 column classification is the more accurate estimation of the bone injury, helps you to understand the injury mechanism, helps to decide the approach which is required for fixation of this fracture. And also it decides the directions of the screw, the position of the screw, position of the plate onto the bone. Then again in 2016, CrossJ gave another classification system. Here they insisted on classifying the tibial plateau in the 10 different quadrants, depending upon this is the anteromedial medial, this is the anteromedial central, and also there is the central zone. So on a CT scan axial section, you can see the different fragments which are there involving the proximal tibia. So his emphasis only emphasizing on the not only the peripheral extent from the where the fracture line is exiting, also the articular depression which is there, and we can plan the fixation accordingly. So another advantage of this process classification is that depending upon the zone of the tibia which is involved, you can plan the management. So all this fracture can be managed with the anterior approach, whereas for this particular fracture we need to go posteriorly. But always don't forget the soft tissue injury, because in young individual it's usually a high velocity type of injury, so there can be extensive damage to the soft tissues. So contusion, open injuries, compartment syndrome, as Dr. Devendra has emphasized on looking for the active toe movement in all these patients, and also the passive extension movement that needs to be seen. Also, we all should look for a peroneal nerve injury, also popliteal nerve injury. So for the classifying the soft tissue injury, you can either, it's in case of the open fracture, you can use the modified Gustell-Anderson classification, type 1, 2, and 3, or you can use the shearness classification for the closed type of injuries. And always before planning to go for any surgical site, you have to ensure that the skin condition is okay to proceed with the internal fixation. So etiology can be axial trauma, not associated with the close injuries, or it can be less soft tissue problems. So in case of a high low energy trauma, the problem is mechanical, like in elderly patient, osteoporotic bone, and high energy trauma, you have to deal with the fracture as well as the biology, because the soft tissue injury may be extensive and we need to manage it before going for the fracture fixation. So investigation in a proximal tibia fracture, these are the standard investigation which are required. X-ray, AP, and the lateral view. 45-degree oblique view will give us the idea regarding the posterior parts if it is injured. Computer tomography is essential and needs to be done in all proximal tibia fracture. Even on the X-ray, if it's a innocuous looking fracture is there, you need to go for a CT scan, because sometimes the central depression or the posterior fracture may be missed on the AP or a lateral X-ray. MRI has a limited indication in proximal tibia fracture. Angiography may be required if you are suspecting some compartment syndrome or some arterial injury is there. So not in all the cases we are going to require the angiography. So you need to study the personality of the fractures. How is the soft tissue damage is there? How much is the fracture displacement? Degree of comminution, bone quality, how it is, whether the joint, how much it is involved, whether there is a subluxation, neurovascular injury, and also associated if there is a floating knee injury. With all this fracture will decide how you are going to plan the surgery or the fixation for this treatment. So ultimate goal for the proximal tibia fracture is the decompression and preservation of the soft tissues, reconstruction of the joint surfaces, and the reconstruction of the normal mechanical axis, and early motion so that we can have a good knee function. Non-operative treatment is a very limited role, only in patients who are not surgically fit or very, very minimally displaced fracture, which are seen on the CT scan, can be managed with the help of a cast and the avoidance of the weight bearing. But as I said, not more than 2 millimeter of the articular step should be less than 2 millimeter. If it is more, it is better to go for operative intervention. So whenever you are contemplating a surgery for a displaced proximal tibia fracture, you need to understand this indications for emergency surgeries. So whenever you are suspecting some vascular injuries, compartment syndrome, open fracture, gross dislocation, floating knee, and the polytrauma patient, damage control surgery comes into play, where we need to span the fracture with the help of external fixator so that the vascular surgeon can go for a vascular repair. Compartment syndrome, if it is already established, it needs to be a fasciotomy needs to be done. Open fracture, in case of gross dislocation also, we have to realign the joint with the help of external fixator. So mainly in those situations, what you can do is that you can span the joint, then you can subject this patient for the CT scan, and accordingly you can plan the surgery. In other patient, whenever there is these emergency indications are not there, so you have to look for the local skin condition. If the local skin condition is not good, lot of contusion, hemorrhages are there, then it is better to go for a spanning external fixator followed by the scanning and the plan. in low velocity type of injury, the fixator application may not be required. So you can directly go ahead with the fixation when the skin condition is stabilized. The timing of the surgery is very important. So in case of the low velocity injury, mostly the split depression or the pure depression type, there may not be associated soft tissue injury. But in case of the 4, 5, and 6 Schwarzgast fracture, there can be associated soft tissue, and you have to wait till the wrinkle sign appears. So one of the treatment protocol what you follow for getting a good condition is the limb elevation, local ice pack application, and compression. And active toe movement is encouraged, so that will take care in reducing the edema. And appearance of this wrinkle sign would be the sign that you can proceed with the fixation. So surgical approach, usually it's a minimal invasive approach. The different surgical approach which already been described by Dr. Devendra in detail. You should always be prepared for the bone grafting. So this can be the knee position. So we can have the CM on the opposite side. Knee needs to be properly supported, so we can have access to both the medial as well as the lateral side. And fluoroscopy is must. So this is the diagram which can show the position of the patient. If you are accessing from the going for the anterolateral approach, the position of the CM and the assistant which can be positioned. So which approach to take? So depending upon this 3-column fracture classification, so this fracture, the middle column can be approached to the medial approach. This posterior column will require a posterior approach, that is the Loban Hyper approach, which is better, as Dr. Devendra has said, it can be done better in the prone position. For this limited type of fracture, where the posterolateral depressed fragment is there, which is not accessible from the anterior side, you may have to go for extensile approach, that is the Frosch approach can be given. So I'm not going to in details of these approaches, which are already been covered in detail very nicely by Dr. Devendra. With the posteromedial approach. So what are the different armamentier you need to have on your table? So that is the bone grafting, bone substitute. Then you should have a distractor that will give in help you in achieving the reduction. Different type of plates, which are the anatomic plates for the different bone fragment, these to be available. Also a joint fixation if required. So mainly we are relying on the fixed angle devices, that is the locking compression plate. Now recently AOA has come with the variable angle plates, where you can change the angle of the locking screw also. That gives you a lot of modularity to apply the plate. So basic principle in case of any articular fracture is to expose the ligamentous and the meniscus structure, reconstruct the joint. So the fragment which is injured needs to be directly visualized, and absolute stability is required. Whereas the metaphyseal fragment can be managed with a relative stability, or a buttress plate can be applied. Also, if it is associated with some ligament or the meniscus injury, that needs to be addressed at the same time. So we'll just go in detail about a different type of fractures which can be managed. So in case of the simple type 1 fractures, there is a lateral split depression of fracture. In the minimally displaced fracture, we can be managed with a closed make without exposing the fracture. You can also do the fracturoscopy, or the orthoscopic assisted fixation can be done. So you can see the preoperative and the postoperative X-ray, where it is showing a good reduction of the fracture after application of the screw. In type 2, that is where there is a split and a depression fragment as there are difficult fracture to manage. So here the key is to identify where is the exactly depression. So CT scan will help you. All the crosses classification will show. So you can compartmentalize or identify the zone where the depression is there. So typically, if there is already split depression is there, you can access the depressed fragment either through the open big type of injury, where you can open up the fracture site, retract it, and directly visualize the fragment. So it can be elevated with the help of punches, and it can be supported with the help of bone graft, bone substitute, and ultimately with a rough plate. There is another technique in which you can elevate this particular fragment, mainly which is useful in type 3 type of Schwarzgast type, where you can make a cortical window on the medial side. Under CM guidance, you can put different type of TAMs inside the joint and elevate the fractures. But whenever you're going for any articular depressed fracture, you need to do the lateral submeniscal orthotomy into the anterolateral part of the knee to visualize the exact elevation which has been achieved. So many a times, if you considering that on CM you are getting a good picture and you're avoiding the submeniscal orthotomy, so that may not be acceptable, because you should always go for a submeniscal orthotomy to visualize the depressed fragment, whether it has been reduced properly or not. So in case of a lateral tibial fracture, the buttress plate is a great advantage. Always use a locking plate. Avoid using a simple non-locking plates. All the type 2 fractures are not same. So maybe on an AP X-ray, it's looking like a single column fracture, but it can be a double column fracture. So in such rare cases where you have the posterolateral fragment depression, which is not amenable to treatment from the anterior side, you can go for the extended posterolateral approach, that is the Frosch approach can be given. And always be aware of the common peroneal nerve. It needs to be identified, separated, and needs to be protected throughout the surgery. Type 4 fracture, the high velocity type of injury, can be better managed with a buttress plate. So either it can be a middle buttress plate and a lateral buttress plate. So in this factor, I want to emphasize the position of the spike. If the spike is present posteriorly, the plate has to go posteriorly. If the spike is medial, which is seen on the AP X-ray, you can get away with a medial plate. So depending upon the position of the spike, you can decide which side plate needs to be applied. So in case if there is depression of the both the involvement of the anteromedial as well as the anteroposterior fragment, you may have to apply 2 plates, or you can get away with the interfragmentary screw, which are placed from the anterior to posterior. Then another case of a type 5 fracture is the bicondylar fracture, managed with the medial plate and the lateral screws. In another case, in elderly patient, as we have just discussed, you have to manage the articular the osteoporosis also. So in this particular case, it's an elderly patient with a middle condyle fracture with some extension to the lateral tibial condyle also. So a lot of the probably the patient has walked onto it. You can see the lot of overloading of the fracture fragment. So in this case, the external distractor comes handy. So that will help us in preventing the varus. So in case of proximal tibia fracture, the most common complication is the post-operative varus. So if you apply a fixator or a distractor onto the medial femoral condyle and the tibia, so that varus complication can be avoided. So different type of bone substitute, bone grafts, allografts can be used to fill up the void, but always use some amount of substitute to fill up that void, because otherwise there is always a chance for delayed collapse. So dual plating, yes, in type 5 and 5-6 fractures, we can go for a dual plating. So depending upon the fracture pattern, we can have the medial as well as the lateral approaches, and always ensure that there should be an intact bridge of 6 centimeter between the bone fragments. So which side to operate first? So I would personally prefer to operate on only on the medial side, because usually it is the less comminuted, and it also helps to prevent the varus. Because if you fix on the lateral side first, and if there is a resultant varus, you can have a difficulty in achieving the reduction on the medial side. So I usually prefer to go on the medial side first, and then from the lateral side. So the different plate configuration which can be used, it can have a small posterior medial plate, and along with the lateral buttress plate can be used. So this is the case in which bicondylar type 6 fracture. So on the lateral X-ray, you can see there is a depression, there is a posterior medial fragment as well as the antero medial fragment is there. So this was managed with the medial as well as the posterior and a lateral plate. This is another example. So even if the injury is looking ghastly, so once you apply and reduce and apply the proper plate, you can achieve a good range of motion even during the just at the time of suture removal. The patient is having excellent range of motion. So in all this patient, whenever there is a dislocation, always you apply a spanning external fixator. So that will give rest to the help in achieving the reduction, reducing the dislocation if it is there, and also the soft tissue healing will be faster. But only thing in such cases is important that the interval between the application of a fixator and the definitive surgery should be less than 14 days. because there have been studies which have shown if you keep a fixator for more than 15 days and then you are planning an internal fixation, there is always a possibility of infection. Whereas if you do within 14 days, the infection rate is almost similar as you go in for the primary surgery. So this is another case whether the tibial plateau fracture, which is managed with the external fixator and later with the bipolar plating. So there is a role for ring fixator. Usually it is now with the availability of good quality plate, the less and less indications are there for external fixator. But yes, in certain cases when there is a compound fracture, where we cannot wait for the surgery, in those cases we can still have a role where you can have a combined fixation. Articular fractures can be managed with the help of the percutaneous screw fixation, and the metaphyseal fragment, if it is there, that can be managed with the help of external fixator. So you can use the modular fixators also, or you can use the Elizar ring fixator can be used. So advantage of this type of fixator is that in case if you want to go for some limb lengthening, or there is a bone loss is there, so that can also be simultaneously carrying out. There are some issues with the external fixator, like attention, the pin track wire track insertion, intracapsular portals, if they are created, that can also result into knee stiffness. And articular reduction needs to be done as early as possible. But most of the time, whoever the patient who have been kept on external fixator, they are not that happy. There is a limited role for total knee joint replacement in primary proximal tibial plateau fractures. So mainly in the geriatric patient, where there is a significant amount of osteoporosis, there already orthotic changes are already set in. So in these cases, there is a role for total knee orthoplasty. But due to the associated meniscus injury, the ligament injury in this patient, most of the time we will have to go for a constrained type of prosthesis. The routine prosthesis may not be useful for the in proximal tibia fractures. Physiotherapy is very much important in this type of fractures, and it should be initiated as early as possible. So emphasis should be given on reducing the edema postoperatively, getting on the active toe movement, static quadriceps exercising, and starting the knee CPM as early as possible as the patient tolerates the pain. Because in the first 4 to 6 weeks, whatever range of motion you are going to achieve, that will continue to improve. But if the patient is managed, if you are not confident about the type quality of fixation, and if you are immobilizing the patient for 4 to 6 weeks, there is a high chance for knee stiffness. Weight bearing, yes, usually I prefer to delay the weight bearing. Toe touch weight bearing can be started at the 4 to 6 week if you are seeing a good quality fixation in the follow-up X-ray. Also, the bone quality is good. But whereas in patient with osteoporosis, you have to delay the weight bearing till the fracture unite. But you can allow the knee range of motion. So when you talk about the results of the ORIF in general, so depend upon the fracture type. So it's a low velocity injury, you definitely have a good results with good range of motion. Soft tissue management is important. Sometimes if it's a compound fracture, you may have to take help of a plastic surgeon friends for management of this soft tissue injury. If the proper management is given, you can most of the patient we can expect a good range of motion. That is 0 to 80, 20 degrees of motion is seen in 87% of the patient, and no deterioration is seen in most of the patients. So take-home message for the postgraduate student from this presentation is that you have to look at the soft tissues and bony injury both, and you have to manage the both. And soft tissue management will take a precedence over the fracture fixation. So in case there is soft tissue injury, always go for span, scan, and plan. And always you should know, if you fail to plan, you plan to fail. Anatomical reduction and radial fixation for the joint surface, that is the absolute stability is required. For the metaphyseal fracture, you need a stable fixation of the metaphysis. That can be achieved with a relative stability. And avoid virus at any cost. Restoration of joint stability but appropriate soft tissue reconstruction is paramount. And early range of motion should be started. And the last but not the least, always respect the soft tissue. So though be careful whenever you are planning the regarding the timing of the surgery and the type of incisions you are going to use. Thank you. Thank you for the patience.
Thank you, Dr. Samir, sir, for such a nice presentations. We have some queries.
Yes,
You
sir.
have
Please.
used the term holistic approach. That is the
Yes, sir.
most appropriate thing to use while you are dealing with a proximal tibia fracture. So the question is asked, how will you manage soft tissue injury in wards before preparing it for internal fixation?
Right, sir. So mainly that in case of a type 1, 2, 3 fractures, it's a low velocity injury. 4, 5, 6 are the high velocity injury. So if on presentation, if you see the skin condition is not good, lot of skin contusions are there, blisters are there, either a serious blister or some hemorrhage blisters are there. Those are the patients we need to wait for the surgery. If associated that if there is a contusion, open lacerations are there, in those scenarios, you better you should resort to the damage control approach, apply a spanning external fixator. So that will not only give rest to the. Hello.
Sorry for the technical glitch.
Yeah. So mainly in this patient, you can go for the spanning external fixator, wait for it, the edema to subside. Once the wrinkle appears, then you can plan for surgery. And also the application of a spanning fixator help in reducing the fracture, and the fracture pattern can be better assessed on a CT scan then.
Sir, what is your average time duration to convert the patient into for internal fixation? So bring the patient to the OT from the time of fracture. What is the
Usually
average
it
time?
is ranges between 4 to 7 days, sir.
4 to 7 days to
Yes.
settle. So, sir, is there any specific protocol post-operatively for soft tissue handling?
Post-operatively, yes. If it's the lacerated wounds are there, it's require plastic surgery management. So we can take help of them, and the wound should be covered as early as possible. Otherwise, if you're using resort to dual plating, the hemostasis, releasing the tourniquet before closing the wound, it's important so that you can achieve the hemostasis and avoid the post-operative hematoma. And also you can go ahead with the early range of motion, ankle pump, and the cold ice pack application, which will help in reducing the post-operative edema.
Sir, another question was asked in your talk. You talk about the ligamentous stability.
Yes.
So how will you check about the ligament injury in acute fracture stage?
Right, sir. So recently I had a patient with a type 3 type of fracture, type 3. There is a central pure depression. So when I took it from surgery, I was able to appreciate there was a grade 2 to 3 medial laxity was there. Okay. Medial laxity was there. So there was a confusion whether this is the medial laxity is because of the collateral ligament injury or it's because of the depression. So we went ahead with the depression, the fracture fragment fixation. We created a window, elevated that fracture fragment. And once you achieve the proper reduction, elevation of the lateral tibial plateau, the laxity wasn't there. So the laxity here was because of the depressed fragment and not because of the ligament injury. In other cases, whether the bicondylar fractures are there, the ligament intactness has to be assessed after the fixation. So once you achieve the fixation, and after that, if there is a residual laxity more than grade 2 to 3, in those scenarios, we have to take some additional steps to stabilize those joints. So if you are going for posterior middle approach, you have a direct exposure of the middle collateral ligament. So in case if it is associated with some avulsion fractures or there is a tear, so that can be repaired directly.
So your take-home message will be first fix the fracture, then assess ligament stability intraoperatively. And if you found the ligament instability, is better to fix it.
Yes.
Okay, sir. So there is also debate going on about the use of single plating versus dual plating.
Yes.
In many fracture, even in type 5 and 6, many advocate single plating due to less incision and less time. So what is your take on it?
Yes, here you need to understand the fracture mechanics. So both this fracture, the medial tibial fracture has a different pathomechanics, and you have to look for the spike. So if there is a bicondylar fracture, and if you're only stabilizing with a lateral plate, there is always a chance that over a period of time, there will be delayed varus collapse. So I personally advocate for a bipillar plating, and with the availability of the good quality plate and respecting the soft tissue, you can space up the incisions, the distance between the two incisions, and you can avoid the complications which are usually associated with this both column plating.
Yes, sir. There is another question coming. Is there any role of variable angle plate in this proximal tibia fractures?
Yes. So variable angle plates are the great advantages to use. So you should be aware of this particular plates. So advantage with this that once you apply a plate, you can angulate your screw 15 degree proximally as well as 10 degree distally. So usually in the conventional locking plates, once you apply the plate dictates that where you are going to put the plate. So many times you may not be happy that the depressed fragment is not very well supported with the help of screws which you have put. The trap plates are not going the direction desired. So advantages with variable angle plate is that even if you apply a plate, you can vary your angle to support your depressed fragment. Because if that fragment is not supported, there is the possibility of a delayed collapse at that particular fragment.
Sir, in your talk, you had mentioned that movement of the knee joint, even done at the 2 week, is as equal as early movement, sir. So
Yes.
what do you personally, your protocol of starting the movement in these proximal tibial fractures in high velocity, like type 5 and 6 fractures?
Yes. So in type 5 and 6 fracture, if the pain is even in the post-operative period, patient can have a lot of edema and the pain can be there because of the associated soft tissue injuries. So in those cases only we can delay the knee range of motion. So I personally don't use a plaster slab. I used to prefer to keep them on a long knee brace and taking precaution that they are not going into flexion contracture, because there is a tendency to keep the limb in extension, the flexion. So emphasis should be on to the active SLR if they are able to do. Then static quadricep and ankle dorsiflexion. So that will help in preventing the flexion contracture. And gradually, as soon as they are able to, the pain is less, we can start with the movement. So in those cases, the CPM is very useful.
Sir, in those, like especially in type 5, 6, sir, how much delay you do for the partial weight bearing and full weight bearing, sir?
I usually wait for the still fracture union. So up to maybe 2 to 3 months.
Okay, sir. Then you start the partial weight bearing.
Yes, yes.
Okay,
and
sir.
also
Thank you.
the bone quality makes a difference. Saying young patient, yes, I can take a risk of allowing them to weight bear properly early, but in elderly patient, it's very difficult to convince them. And many times when you say that you have to put 50% weight, invariably they end up putting their whole weight onto the limb.
Thank you, sir, for clarifying so many doubts and putting the light to many facts on fractures of proximal tibia. Now I will invite Dr. Birendra to continue the session that has been interrupted by the technical glitch. Over to you,
Dr. Manish, if you permit, I have some question with Dr. Samir.
Yes,
before
yes,
going to Dr.
Yeah, please, sir.
Yeah, Samir sir, you said you fix first medial then lateral.
Yes.
Then what about 3-column fixation if you want to go with the posterior also, because it's cumbersome to get posterior fixation first and then again change the position? What's about
No. Yes, sir. Yes, sir. So what I'm trying to say is that, see, you have to avoid the varus. Suppose it's a 3-column fracture where the lateral column, there is an anteromedial fragment is there and a posteromedial fragment is there. So in this case, my first approach would be a posteromedial approach in the supine position, where I'll be fixing the posteromedial fragment first to correct the depressed fragment, and also align the anteromedial fragment to the posteromedial fragment. So that will take care of my varus and the both the medial fragment. Once that is achieved, then I will go for the lateral tibial flexion. The scenario when you're talking about where there is a posterior fragment, pure posterior fracture, and there is an anterior fracture, yes, in that case, it may be required that we may have to go posterior, because whenever there is a fracture, is mainly involving the area which is near to the insertion of the PCL. So those fracture can be easily managed with the prone position. Reduction as the limb position, because of the gravity, it is very easy to get the reduction in the prone position. One that is done, you can close that wound and then you can come over and flip over the patient to the position.
And one more question, sir.
Sir.
Many of the time patient came with the POP slab, long POP slab.
Yes.
PG could not have seen the whole leg. They said only that there is no blister. Patient posted in OT and then fixed. After that, we saw that common peroneal was involved. What are your message here?
So in that case, the message is very clear. Whenever the patient comes in, sir, you have to open the cap. You should have not only look at the X-ray, but you should also have a look at the soft tissues.
Thank you very much.
Thank you, sir.
Dr. Manish, may I proceed to invite Dr. Prasoon?
Yes, yes, Dr. Govind, you can.
Yeah, Prasoon sir, are you audible?
Yeah, am I audible?
Yeah, you are
I am
audible. Please put your slide.
keeping my video on pause.
Are you audible, Prasoon sir?
Yes, is it okay?
Yeah, now your slide is visible, and please start from where surgical mantras.
Okay. Am I visible? Am I audible?
Yes, it's clear,
Yeah.
and all slides are visible well. Please proceed.
Okay, so we are talking about, in spite of locking plate being so widely used and so successful, we have seen so much of failure rate with the use of locking plate. So now we are discussing what is the success mantra to have a good outcome. First, the longest possible plate has to be used. What if longest plate means more than at least 11 holes, and against the direct anatomical reduction has to be an absolute stability for the articular block is must, and indirect functional reduction and relative stability for the metaphyseal and diphyseal segment has to be done. Hybrid fixation means not all screw has to be cortical screw, either cortical screw or locking screw. It should be mixed of both cortical and the locking screw. Screw density has to be less than 0.4 to 0.5, means if 10 hole plate is there, it has to be maximum 4 or 5 screw. Not all screw hole need to be filled with the screws. It will make the construct very rigid and it's prone to failure. Minimal 4 screw in each segment is required for the optimal stability, and medial augmentation whenever required. If we are using a lateral based plate, whenever required, the medial augmentation has to be done. So these are the things we need to know and we need to practice to avoid the failure. Now, regarding the medial augmentation, what are the indications? If the distal fragment is very short and lateral plate screw is not going to give a proper stabilization, always go for the medial augmentation. In case of osteoporosis, same thing apply. Periprosthetic fracture, most often it will need a dual plating for the optimal stabilization of the short fragment. If the medial gap is more than 2 centimeter, one should go for the medial augmentation. And whenever in doubt, after lateral based fixation, whenever we have doubt, always do not hesitate to go for the medial augmentation. The study has shown that if you use a single lateral exposure, the damage to the vascularity to the distal segment is 25%. And if we go along with the medial exposure to only 29%. So there's a difference of only 4% in vascularity. So one should not be afraid of using the medial augmentation in fear of losing the blood supply. It is only a marginal loss of blood supply. So there various method has been described for the medial augmentation. Dr. Sunil Kulkarni from the MIRAS, they have shown it beautifully. They have got a paper, they have got a lab demonstration also where they have done cycling loading. So they use the Anders nail and tens nail also. So the benefit of using this elastic type of fixation, that it is a very quick procedure, minimal invasive, and it is effective also. Now, the most commonly used for medial augmentation is the plate. And we have got the plethora of plate option. Each and every plate has been used for this, like Philos plate, distal medial tibial plate has been used, Tomofix has been used, 3.5, 4.5 reconstruction plate, locking plate, T-buttress plate, all has been used, but what has been seen anatomically that proximal lateral raft plate fits well, and that serves the purpose very well. And now we have got commercially available anatomical plate for the medial augmentation too. The nail plate combination also can be used to support the medial combination. And in primary case also it can be used whenever in doubt, and in failed case it has definitely got a lot of benefit. When you use a locking plate, we should be aware of few things, that the distal first screw has to parallel to the articular surface to have a good anatomical axis restored, and in lateral view we must put the screw in a trajectory knowing the trapezoid anatomy of the femur. And as I have already discussed, the anterior screw should be shorter in length than the distal screw, and we should be mindful of posteriorly intercondylar notch and anteriorly the groove. The retrograde nail for type up to type A to type C2, maybe C3, is not a newer thing. We have been using the supracondylar, the first generation supracondylar nail since our PG days. The advantage of the nail is a load sharing device. It can be put in a minimal invasive way. It maintains the length, and the reaming itself has a positive effect on healing. But the disadvantage is that it has got especially the previous generation nail, it has got insufficient distal articular fixation. So there will be loss of reduction and malreduction. There will be knee stiffness because knee joint is interred, and because it is not giving adequate stability, it will need augmentation with plate or something. So again, the plate nail combination. The supracondylar nail, what I have talked about, the previous generation, which has got 3 uniplanar screws. So the disadvantage of this previous generation is that it has got uniplanar screws, less number of screws. So in osteoporotic bone or maybe combination, there is a risk of toggling and the screw coming out and loss of reduction and the failure. But we have got the multi-nail. Basically, all the multinational companies are having. Now the Indian company has also come with this. The advantage of this, that it has got the multiple screw option going in different directions. So it locks the articular block effectively, and it has got longer nail of variable length. Ideally, the nail tip has to stop at the level of up to the level of LT, so there is no stress riser, and it has got anterior-posterior screw for the ease of distal locking. So with the resurgence of nailing in this new design, many surgeons are shifting from plating to nailing. One has to begin mindful that nail itself is, because the metaphysis is roomy, nail, unlike the diaphyseal fracture, nail itself is not going to reduce the fracture. One has to reduce the fracture and put the nail, and for that, a lot of techniques are there. One of these very effective is the polar screw. For type B and B2 is a partial articular sagittal fracture. Putting the lag screw alone or supported with the buttress plate is a good option. A special mention to the type B3 is a coronal fracture, Hooper fracture, because many times these are missed and even treated, they are not treated well. So there is a Latiner classification, which type 1 is the complete vertical fracture, type 2 fracture, and type 3 is a oblique fracture. So conventionally and most commonly, what we are using, we are putting a 3.5 or 4 mm solid or cannulated partially threaded screw from anterior-posterior direction, and it is very effective, easy to use when the fracture fragment distally, posteriorly is a bigger one, it holds well. But biomechanically, it is shown that screw put from posterior to anterior direction give better stability, augmented with the plate, buttress plate, it gives better stability. And if the distal fragment is, posterior fragment is short, then it, it is always better to put a screw from the posterior to anterior, augmented with the buttress plate. But the doing it technically becomes difficult because you need different exposure. And one should be aware of those exposure, posterior base exposure. The newer technique has come with the subcondylar raft plate for the Hooker fracture when there is a comminution or there is an impaction in between the fracture. Only screw from anterior posterior not going to give absolute stability. So here comes the role of subcondylar raft plating, and it gives very good stability for the unstable comminuted Hooker fracture. And it can be made with a simple recon plate which can be turned and twisted as per our need. And lastly, if there is a multiple attempt of reosteosynthesis has been done and it has failed, very short articular comminuted fragment is there and very osteoporotic. So in those rare case, we may need to think about the mega prosthesis replacement. It has got a limited indication, but definite indication is there. So in summary, for successful outcome, we must accept that it is a challenging fracture, and therefore preoperative meticulous scanning and planning is must. Thorough understanding of the distal femur anatomy is must before embarking on any surgical adventure. Again, need not to be emphasized that direct anatomical reduction and absolute stability for the articular block, indirect reduction and relative stability for the metaphyseal diphyseal segment. We must be aware of different reduction techniques and the tools because this is challenging fracture. So we must know what are the different reduction techniques and tools available to us, and we should keep plan A and then B and then C also ready. Choosing and apply the correct implant is very important because many times it is not the technique or implant that is at fault. It is our understanding and how you use the implant that makes the difference. And lastly, needless to say that whatever we do, we must respect the biology for the optimal outcome. Thank you so much.
Thank you, Prasoon sir, for your nice deliver. In the mean, we have stopped you because of some internet issue, but again, you finished very well. Sir, few words we want to know from you. Prasoon, Dr. Prasoon, are you audible?
Yeah.
Tell me in a brief, when to choose plate, when to go for the nail. Few words, sir.
When to choose the plate and when to use the nail.
Yeah.
See, plating can be done in all circumstances. Nailing has got a lot of people up to C3 fracture, they are using the nail. But for the average surgeon, up to C2, the nailing can be used. The advantage of nail that only single implant, and now we have got the multi-lock plate nail is there. With a single implant, we can stabilize the fracture and without bothering about the medial comminution. The locking plate has got the benefit that it has got wide applicability, but we are worried about the medial comminution. So if medial comminution, we need to augment it. So now a lot of surgeons, they are shifting again from the plate to the nail as a single device.
Okay. And in primary case, it's not revision about revision, it's a primary case. When you go for the bone graft.
See, if there's a comminution, there's no need for bone grafting. If there's a comminution, but in open fracture, suppose open fracture or there's a bone loss condition, then we need a bone grafting. Otherwise, in a non-open case, only commission is there, only we stabilize either the lateral base or lateral plus medial augmentation, and the bone will reform.
Okay. And would you like to go to add teriparatide in osteoporosis fixation routinely or case-wise?
See, literature is divided. To use of teriparatide is divided. See, whether to use for the early healing or not. For osteoporosis, it has got definite role, but whether it promotes healing, there is always a doubt and debate about this. But in my limited experience in using a teriparatide, I have got very good result. I routinely use in osteoporotic fracture, and my experience so far, although it is very limited experience, but my experience is all present.
And one last question, sir. Whenever there is distal femur fracture, the distal fragment used to go posteriorly. Would you like to go in all cases to rule out for the angiography before fixation?
Getting angiography in every case is far-fetched idea, but we must, look for the vascularity, any vascular compromise is there or not. So simple clinical examination is going to solve 90% of problem. If we suspect any disruption of the blood vascularity, then to confirm that and to exactly localize where is the block, we can go for the angiography. Otherwise, routinely it is not required.
Okay. I would like to thank Dr. Prasoon for such a clear answers. And again, Dr. Manish is invited on the dais.
Thank you
to take
all.
over this.
Thank you everyone to putting all your energy in conducting this webinar. This webinar is primarily aimed for teaching our postgraduate student. So from the Jharkhand Orthopedic Association, we are thankful to all our speakers, our coordinators, and hopefully we will come with another episode very soon. So thank you everyone.
Thank you, Dr. Manish.
Thank you. Thank you, Rajesh sir. Thank you, Samir sir.
Thank you,
Thank you,
Manish
Dr.
sir.
Prasoon. Thank you,
Thank
Dr.
you, Biren.
Thank you, sir.
Govind.
Thank you so much. Thank you.
Thank you.